was thinking when I had the opportunity to moderate this panel, like, yes, I'm an OBGYN, and yes, I do this every day, and yes, I work at Boston Medical Center, but what are my own individual thoughts about this, and why would this make sense, particularly this community element? And I think, there are a couple things that I want to mention very quickly that I think were touched upon that I want to highlight so that they are addressed in questions and perhaps in commentary by Dr. Bryant when she comes to speak. I think centering, although I did hear from Karen, I actually was at a talk that with she and Fifi were on Monday night last week, I think. Centering has not been shown to be as effective as we would like to think that it would be in affecting outcomes. However, as someone who's done centering in pregnancy for the last, 7 or 8 years, I would say I think that in addition to learning your patients well as providers, there is a middle tier of community that is created amongst those women that can oftentimes help to supplement whatever the community is and serve almost as a group doula-like experience for some of those women, because there is support that we see before delivery and even extending beyond delivery within that community. And I've had centering groups where people come back, 2 women to the same group several years later who stayed in touch ever since their, between their pregnancies, which I think is extraordinary. The second thing is I wanted to just mention this whole idea of interdisciplinary approaches. So we, yes, should include family planning, and in fact, one of the fellows at Boston Medical Center, the Family Planning Fellows, is looking at the impact of racism on women around reproductive choices beyond pregnancy, such as contraception and abortion and spacing. And does racism disempower women, and what are the stressors and the expectations within society related to race for women as they make these choices? But don't forget, as OBGYNs, we lose women. They leave us and they go see primary care doctors, or they go see they see other family medicine doctors, or they don't see anybody until they come back and they're pregnant again. And we have not yet figured out how to include that discipline, whoever that is, and that is many people. That is some emergency medicine doctors. It's some internists. Sometimes it's the pediatricians who are talking to the mothers when they're seeing the children, and we have yet to even begin to explore that, and I think that's another dimension. Questions for our panel? I have a question, and then it looks like you have a question too, but so this is in keeping with what Dr. Molina was talking about in terms of concordance. So this is specifically for you, Nneka, in terms of, do you think it matters that there be racial, cultural, ethnic, experiential concordance between doulas and patients, and how does that impact the discordance that we see given our health provider workforce, and I'm going to include midwives in that because there are not a lot of midwives of color either, actually, and our patients that we are currently discussing here, our patients of color.
Well, I think the second part of that question can be answered by looking at who is actually in the room today. Look around. First portion, I think walking into a space and seeing a doctor that looks like me, or a midwife that looks like me, or a nurse that looks like me, I'm more open to tell them the truth about what's going on with me, regardless of whether I'm going to see an OB. Case in point, my fourth pregnancy, my rainbow pregnancy, I had the pleasure of having Dr. Laura Riley, and I thank God I was 41, because I probably would have gone back to her a few times before she switched I would have just gotten pregnant for that experience. Seriously, I mean, it was the best experience ever to be cared for my birth plan to be taken as Bible, to negotiate my 37-week induction. I went to her knowing more than I've ever known before, because with the first 3 pregnancies, I didn't even know what a doula was. That was the only pregnancy that I was aware of how my body worked. And I think that's another key, teaching our women before they get pregnant how their body works, going into our communities saying this is what a doula does, This is how she can, or he can provide support to you throughout your pregnancy, and so on and so forth, as a person of color talking to another person of color. This is why I became involved with the Community Action Network. I've been involved with them from day one, pretty much, from the first year of inception, and I plan to be with them until they're no longer there. Because I look around and I see a beautiful rainbow. No one is belittled. Everyone understands, and if they don't understand, there's someone there who can explain it to the fullest. We have all come together, even with planning the mission, planning whatever. There's no one person making that decision for us. It's a true community, and what a community should look like and be modeled after. Did I answer?
I think so.
Okay.
Samantha, could I also say something?
Absolutely.
One thing I had meant to mention was, even in research or doing focus groups or the needs assessment, it's critically important to have people who are running the groups mirror the communities or be part of the communities. And so one thing we're doing this time that we're doing the needs assessment is really training community facilitators in running the groups. Last time, I love being in those focus groups, but I'm white, I'm old, it's like, I think that I'm not that old, but I really believe that having this concept of participatory research, as well as similar to what Dana was saying about participatory program development, is critical, because we're not going to really know what people may not speak with such authenticity and may not feel that they can speak truth to power when power is sitting right in front of them, so much as they can really talk about their experience with people who they feel that commonality with. So that is something we're really excited about doing this time, is really training the community researchers.
Do you want to make a comment?
Yeah.
Go ahead.
I want to make a comment.
For recording purposes,
I think I'm still concerned that we have to choose where we go for care, try to find the people who look like us. In terms of the population in the United States, we have 80% or more white and less of the other groups. So the workforce itself will never mirror the population to the extent we want. When you walk, I was giving a talk at the UMass Medical School. I was shocked that there were only like 2 African American students in the classroom. There were like over 200 people. So we are not allowing enough of the African American people or other people of color to be in the schools to begin with, to be in the professions. So the expectation that we would see them is kind of making the choices difficult for us. It would require that you travel from your town to the town where you can find a nice Dr. Meadows to give you a hug when you walk in her office, or not to go at all. We do see people who decide not to go at all, right? I think we need to be in a place where we can freely walk in any hospital or community health center, knowing that we would be cared for like a human being. Physicians, we swear, when we finish that medical degree, we've completely forgotten what it is to not cause harm, which is what we swore. All of us have. So I think the conversation should go back to, how do we create a space in our services, hospitals, community health centers, everywhere, where people can come and feel safe? Because at least as far as I'm concerned, you call the hospital a place where you go to feel well. It's a place where we get well. How can we not provide that? I think it's pretty simple. We've forgotten the basic human right and why we're physicians. It's either you like the profession, you do your job, or you don't. So we need to restate the conversation. And the other comments is related to the one key question, which has become pretty popular. In some communities, reproductive health is a private matter. When I have sex and when I get pregnant, that's my business. It's none of your business. So not everybody is open to having those conversations. From a religious perspective, in some religions, like Muslims, they're required to do whatever, to be a good wife. So having the conversation in a different way might help address the problem. You can't just tell them, when are you planning on being pregnant? When are you going to have sex? No, hell, nobody knows that. So I think we need to think about how we do that conversation. I know it's awkward coming from an obstetrician, talking about family planning, but it's a reality. It's something I learned from the patients. So I just wanted to put that out there, too.
Can I respond to that?
I often say to my daughter, I'm not that kind of doctor, so I'm not going to speak for a physician because I'm not a provider. But one of the things that I've learned in cultural humility, particularly coming from providers, is, finding some kind of tool or philosophy in this case that you practice and how you interact with your patients. And so if you are interested in it, I would tell you to. Y'all have heard of cultural humility? Some people. Okay, so Dr. Torvalon is and I think she's coming to Boston in October, by the way, to do a training. So I don't know who's sponsoring it out, if you want to find that out. But I think having those conversations and learning how to address the power imbalances. I watch my grandparents, for example, go in and not ask a question at all because there's this sense that the physician knows all, and who am I to question, even if it's me, even if it's my body. And I think a lot of people have that. And what ends up happening is if we're the authority, we take that power on. And we need to learn to mitigate that power. And some people do it better than others. And I think that also is with service providers, right? I think it's not just in provider-patient relationship. So that's one of the reasons, I really like cultural humility, because I think it's a really good tool to really step back and think about, who you are and what do you bring to the table, and then how do you address other people, even if you are in a power position. Because you're right, every place that we go the person's not going to look like us. And so I have to know, as an African-American woman, that the person on the other side is going to follow some kind of strategy that is going to make me feel comfortable or as safe as I possibly can feel. But I don't know that. I have no reason to think that even.
Thank you. This was an enlightening panel. I have to say, Karen, you enlightened me on something that I really didn't think about. I like to say often that our state PQC is the formal bridge between the clinical care system and community, and not community, public health activity. And the way you brought it up around home visiting, it seems like that's a natural one. And I have two questions, one for you and one for you, Nika, on this issue. And that would be, in the structuring of home visiting, has it ever been discussed to have home visitors interface with women during their prenatal care so that they're more likely to accept home visiting, since the rates were only 50%? And then I'll just quickly ask the next question and then let you both speak. And then Nika, specifically to doula care, I was at a delivery last week with a woman who had a baby by herself, and I was blown away. I had to lead the delivery despite the fact the anesthesiologist is going to lose her mind because this woman had HELLP syndrome, and I'm trying to find somebody who can come in here to the hospital and be with her for this delivery. And I found out afterwards that the Brigham does have a doula center, a service for women, but it wasn't advertised, and so I didn't know how to, even if I would have known beforehand, I wouldn't have known how to use it in that way. And so as I put in a plug for part of the conversation we're going to have tomorrow, my question to you is, the Reed Scholars tomorrow are going to be talking a little about digital health, and I haven't heard in any of our conversations where technology plays a role in this, and I'm wondering if there are apps or something related to doula services so that we can have a better conversation of knowing how to help connect women to people who want to be connected to them to support them. So I'll let you answer, Karen, and then come back to Nika.
Sure. So some of the home visiting programs are really community health workers, and well, they don't consider themselves community health workers so much as peer support. They're paraprofessionals. They receive extensive training in motivational interviewing and working with families. And yes, they do connect with them in pregnancy. And yes, their role really is to link with the prenatal care provider. One of the home visiting, our homegrown home visiting, there's a nurse, there's a mental health provider or a social worker and a community health worker. And the nurse does a lot of that linking around with, around the issue of pregnancy and who do they want when they're in labor and connecting them with the doula. And in fact, one of the programs, the EIPP program in Somerville, connects with the Cambridge Health Alliance doula program and really tries to work with the doulas to get them hooked up. So they do. I mean, I think it really helps a lot of people to have a nurse on the home visiting team because sometimes, they want, let's see, how do I phrase this? Sometimes they really want someone who can interpret the medical system in a way that they feel heard, tell me about what hypertension is. Tell me about, they threw this word at me and that word. And, having a clinical person on the home visiting team really helps with that translation. So, yep, I mean, I'd love to have, again, looking to our international partners, I'd love to have universal home visiting for everyone prenatally up through 5 years of age. But
To sort of respond, we are seeking a doula. We currently have a doula bill in the House, and we're tweaking that a little bit to reflect not only birth, but postpartum and bereavement support. So I'll be meeting with someone in a couple of weeks so that we can add in a specific amount of pay so that not only will parents who are on Medicaid, Medicare, whichever, thank you, be supported via birth, but also throughout the first 40 days postpartum. In response to the technological support, we do have a Mass Doulas, I don't want to say website, but since you're in the Boston area, we do have sort of a hotline through BASC, and I will make sure that the information is provided. I'll send email the information as soon as I get home. Different information because it reaches the Mass Doula's email, or we have like this Google group where if someone needs a low-cost or free doula, or if someone can afford to pay, it's posted in this group, tells the person when they're giving birth, where they're giving birth, et cetera, and we just respond as needed. But for an emergency situation, you should have been able to contact Anastasia at the Brigham and say, we need someone now. And someone should have been there. Ideally, we would follow the Brooklyn, New York Public Health Commission, where they have a doula program that's built into their Public Health Commission, and hopefully we'll get there. I'd love to see a postpartum doula program to support a family not just with 1 to 3 visits, but with the first 40 days postpartum to a year. And with this doula bill, that can happen because insurance will pay and we don't have to find funding to support that. Does that answer your question? Okay.
Other questions? Do you have another one? Is that what you were going to say?
Thank you very much. Actually, I wanted to follow back I really appreciate the question about do we have to look for providers that will take care of me as a human being? And I think my question, and it sparked my thinking, and I love the fact of the cultural humility concept of as provider and also as a human being. What is more important? Do I need to seek a racially congruent provider or a culturally congruent provider if we're all human beings? And I just feel that the concept of racial differences, we don't choose that. But cultural differences, we can get trained, we should be able to embrace. And that is the opportunity of change instead of like probably reinforcing a little bit more toward racial segregation. So I don't know if I can hear a little bit more about how you think, especially I really appreciate you like nodding your head, like the doulas and thing. And like, for example, my patient, I was raised Hispanic, and when the patient come in, they ask for La Chinita. And that feels very, like, probably for people who feel like she has a name, but having a name does not make you be identified, but being called La Chinita, they has the freedom to call me like that. That is what helped me be identified with them. And like I would love to hear from the panel and also from the audience about the cultural congruence of provider with patients. Thanks.
I can say something about cultural congruence really quickly. So there have been some studies that have been done that look at gender, they look at race, they look at socioeconomics, they look at linguistic concordance, and they look at all of these things. And while all of those are very important, and there's a number of studies that will show that there are certainly increased adherence to medications, perhaps some of them, the ones that have been touted most frequently. This is a lot of Lisa Cooper's work where they're looking at diastolic and systolic blood pressure numbers with concordance and finger sticks and things like that. But I think that the other piece, the body of literature, speaks to creating these spaces for both cultural humility, cultural appreciation, and flattening of power dynamics. And I think the way that at least the AAMC, the Association of American Medical Colleges, is looking at it right now is around this idea of curricula around racism and advocacy, and in medical school trying to address how it is that we begin to teach students the history of the impact of racism, discrimination, socioeconomics, politics such as redlining, policy and legislation on health outcomes. And if we are able to begin to educate medical students about that, we would then cultivate a generation of physicians where concordance matters less, significantly less, because they are coming in with a very clear understanding of how what they are bringing to the room and how the patient, and what patients bring to the room impacts that interaction in the context of the history of racism, discrimination, socioeconomics, geographics, immigrant status, gender, sexual orientation, and all of the things that we know play a significant role in increasing distrust. And honestly, not only distrust, but misunderstanding between providers and patients. And then you actually probably, Dr. Molina, has something to say too, as well as Dana. Do you want to say something?
Oh, I'm sorry. I just read that way. I was just going to say, like, as a public health professional, I'd say that exact same thing sort of is happening. You know, in the earlier days of my training, we heard really nothing about racism and discrimination, and you know, now it's sort of the buzzword, and students are getting it earlier and earlier, and I think it is extremely important because some of the policies, some of the practices have some overtly racist tones to them, and some, you know, underground sort of racial tones to them, racism tones to them as well, and so the distrust between community and provider community and public health professional, whoever is there, and so until we start getting that information out, I think, and putting it into training programs, we're going to be in the same situation. And I think race concordance is extremely important, but I agree with you that I think if people are beginning to understand that everybody's people aren't coming at it from a racist perspective, then that trust will be there regardless.
Other comments?
There's a program out of the Community Training Institute that teaches, I was recently a part of a cohort there that really delved into racism and how it starts, how it forms, how it keeps going, and then how to break it down. I mean, I've been Black my entire life, and I had never seen anything like that in my life, and I went home and was blown away, and I've been putting things in like little triangles ever since. But that's a good place to start, getting trainings like that into facilities to help people see that even though they're Black, they still have these biases towards other Black people, and so on and so forth. So that's an excellent place to start. And also looking at models around the United States that work, such as Jenny Joseph's model out in Orlando. I'm trying to bring her here for her community health training in October. So be on the lookout for that, because she has recently rolled out a model that helps to put together, it helps us to get a feel for her her centered-based program out of Orlando. And she's sharing that knowledge, and I can't wait until she gets here because it's so very needed here in the Boston community.
So we have 2 minutes. You have a very short question with a very short answer, maybe?
I do.
Oh, yeah? You can control
Okay.
that.
A few people today have brought up the importance of having more reproductive options available to women. And full disclosure, I almost died 2 years ago from side effects from birth control pills. And I know a young lady that died 3 weeks ago, 24-year-old, from pulmonary embolism from birth control pills. And we know that many of the same factors that increase rates for maternal health mortality rates also increase side effects to birth control options. And just in the discussion today, I don't want people to leave thinking that reproduction is the solution, and making sure that we take a holistic approach to this issue.
Okay. So we are going to have some commentary today from somebody I'm so excited to introduce, because I will say that in the, I don't know, like in the 10 years since I finished the fellowship, we have been essentially in the same city and have never actually worked together. But we are part of a very rich group of OBGYNs who completed the fellowship, who we would like to have a picture with actually after this panel. So do not leave, because there's a lot of us. It's very exciting. So Alison Bryant is an associate professor of obstetrics, gynecology, and reproductive sciences at Harvard Medical School. She is entirely educated within that system. Took a short little jaunt to California, where she was at UCSF doing some of the work that she then came back here to do, which is looking at Black infant health and women's health. On the San Francisco Department of Health Women's Advisory Board. Here at MGH now, she's a vice chair of quality, equity, and safety in the Department of OBGYN, and this is a role that she designed, because we hear a lot about quality and safety. The equity is the part I imagine she stuck in there, in an effort to try and underscore the role that equity in healthcare plays in terms of creating quality care across how we provide health to our patients and within institutions. There's a lot of other stuff on here. I think most notably, you see a lot of stuff about ACOG, which is our both legislative and clinically, our clinical advising organization. They set our guidelines, and she actually has co-authored the Alliance for Innovation in Maternal Health Reducing Peripartum Disparities Safety Bundle. So all of those things that we're actually trying to institute and our review and guidelines around that were co-authored by Dr. Bryant.
So good afternoon, everybody. I am honored to try to close out this session that has been amazing. It is not an easy position to follow all these amazing and dynamic speakers. One thing I will say is that I am not in the least bit spontaneous, so the notion of sort of spontaneously commenting on anyone's presentations was fearful to me, so I did present some slides that I will use today. But I think it's been a really powerful afternoon, and what I'd love to do is to maybe contextualize some of the things that we've heard and think about how we can think about them, things that each of you can do when you go home today and go back to your institutions, but also thinking sort of on the national and sort of even international scale. So as we've heard, really there's been a sort of an overweight perhaps of the maternal here, which I think has been really sort of appropriate. I have no financial disclosures. Those who know me know well that my one disclosure on every talk I give is that I'm a native New Yorker, so I talk real fast. So I have like 40 slides to get through in 15 minutes, and I have no doubt that I'm going to do it. Also, I'm like hyped up on Sudafed, so I should be all set. This is my other disclosure from last night. So those of you who are my Facebook friends will know that this is our guinea pig that we have had for 17 days that fell on the floor and sustained a femoral fracture. So if you see the x-ray, that was last night at 9 p.m. I was at Angel Memorial in Waltham, sort of, expediting now a transfer to the quaternary care Angel Memorial in Jamaica Plain for an open reduction fracture. people who know me from New York have said, like, you've been from New York City a long time when you allow a rodent into your home, and now I have done so much more. And the question is, how did that get to this place? And one of the things I would say is that motherhood changes you, right? So motherhood changes you. I've been blessed that motherhood just changed me for the better, but we've talked a lot about today about motherhood that has caused harm for women, and particularly women of color. So I want to talk a little bit about that. So also when I give talks, this is oftentimes the first slide of my talk. So this is an issue of the Boston Globe that was from 2002 that still sits in my office today. It's my personal kind of aha moment about disparities. So it sort of says, infant mortality of blacks on the rise. I was a chief resident at the time in the OBGYN program here, learning much about clinical care, and this very much resonated with me, but I knew that I wasn't going to hear much more about this in my maternal fetal medicine fellowship. And that was perhaps the inspiration for actually doing the Commonwealth Fund Fellowship as the second year of my MFM fellowship. Those who know me well as well will know that it was not that hard with my OCD and sort of, hoarding to find the exact USB drive on which was saved my practicum presentation from 15 years ago. Thank you very much. Thank you very much. And so 15 years ago, May 6, 2004, I presented on the impact of the Medicaid family planning waivers on racial disparities in pregnancy outcomes. And what I tried to convince the audience of in my background slide was that infant mortality was the proxy for the health of a community. And that infant mortality really was the barometer for the health of the community. And what we've all learned today, I think, is that's really not the case. There's a new metric in town. And really how a community treats their women, how they treat their mothers, really says a lot more about the character of a community. And this for us really is our great national tragedy, and this is our great national embarrassment, these disparities that we've seen. I often have patients who say to me, they know I have two boys, they say, Dr. Bryant, are you going to try for the girl? And every time I hear that, I think about this big orange bar, right? So this is 0.2% chance of death. That is me, right? African-American woman over 40. I'm not naive enough to think that my sort of upper middle class or my education is going to protect me from that statistic. And so that's what we've been talking about here today. We heard a little bit from Dr. DeClercq really about pregnancy-related causes, so hemorrhage, emboli, sepsis, but really that we should need to be thinking as well about the things that dwarf that, so the pregnancy-associated causes, because there are disparities in all of these, and we tend to talk much more about the disparities in pregnancy-related causes. This has been sort of echoed a lot in our own professional societies. So in the maternal fetal medicine world, we really were going far left on the fetal side. So, a lot of stuff on prenatal diagnosis, a lot of stuff on sort of growth restriction. And about 7 years ago, the society sort of reined it in and said, we really need to put the M back in MFM. And so I think that on a national stage is where we are, and that's what we've heard a lot about as well today. I did sit on the ACOG Committee for Healthcare for Underserved Women, and so I had the pleasure of revising the committee opinion on racial and ethnic disparities in healthcare. And what we really wanted to highlight were those disparities that were egregious. We wanted to highlight those things that we didn't hear that much about. But in particular, what was important to me was to really talk to the provider about their role in terms of causing and perpetuating some of these disparities. So this is a rubric I tend to use from the American Journal of Public Health, and what I think is important is really talking about the role of the provider, talking about what we've heard today, the role of the place where the provider and the patient meet at the level of clinical encounter. What's missing from this, though, is the structural factors, right? So if we really played this to scale, the structural factors would dwarf out everything, but then you wouldn't see anything, so I put it in the corner. And so what we've heard today really are two distinct panels talking about changes that we can make within the context of the healthcare system, but also the things that we can change in the level of the community, and that pregnant women sort of float in between the two. But truly, if we think about it, pregnant women live much more of their time in their communities than they do in the healthcare system. So while we need to work together, we really need to be investing much more in the care and the attention that we're paying to community level interventions. You just heard that we were part of this effort to create a patient safety bundle around reduction of peripartum disparities. And this was something that we were really quite proud of. So the Council for Maternal Safety and Maternal Health created a number of evidence-based bundles, and they really started with the big three, right? So hypertension, hemorrhage, VTE prophylaxis. And yet they elevated disparities as being an equal threat to maternal health as those other clinical conditions. And so our job was to try to create sort of actionable things that we could do to sort of reduce peripartum disparities. And you've heard a lot about these today, particularly from Dr. Molina, talking about things that we can do in the setting of the healthcare system. And so I just want to talk a little about some of those things that we do in our hospital that you could take back and do for yourselves. So we, as you heard, I created this topic. I said I would take this job of being the Vice Chair of Quality and Safety, but only if we could call it the Vice Chair of Quality, Equity, and Safety, right? So there is no quality care without equitable care, and we hammer that home with our providers. So our job is really to raise awareness of these inequities. So that's one of the things that Bundle says that we need to do. This is a picture of my door. So just talking about our own statistics in our hospital, right? So African American women are more likely to be readmitted. We present that at every QA meeting that we have. We ask everyone to talk about the race, ethnicity, the language proficiency, and the insurance status of the patient every time they present at QA. So if someone's had an adverse outcome, you're presenting all of those things, and we should be thinking about how those things might have influenced the care that you received. Also, I just want everyone to sort of think about data collection. So we heard a lot from Dr. DeClercq about data this morning, or earlier this afternoon, and really the value of self-report. So I challenge you guys all to think about in your own institutions how this data comes to be. These are my children, who people might say are perhaps ethnically ambiguous, right? So if you're in the pediatrician's office and the front desk is assigning them a race ethnicity, how do we know that they are getting that right? And so I have multiple occasions tried to challenge the MGH registration line to see if they get it wrong, and they never get it wrong. They always ask me how I want this listed. They asked it first in an open-ended way, and then if I can't, they give me prompts. When I say that I want them listed as biracial, they ask me which I want to be listed first. Of course, I say African American, and they do it every single time. And so what I would challenge you, because I think that that is not happening across the country, and if we don't have adequate data collection, we are nowhere. So I would say go back to your institutions and figure out how this is collected and see if you can make that as a change. We heard a lot about bias, so we have done our own sort of implicit bias training. We required all of our providers, all of our environmental health, nutrition services, everyone needed to do an unconscious bias training, anyone who touched patients in our department. We required our CNM and our MD providers to do an implicit association test, and we leveraged things like a quality incentive bonus to get it done, right? So people have limited amounts of time, but these are things that are important and can be incentivized. And then we continue those discussions in our workplace. So we had a race and ethnic town halls, and then we had the YWCA Boston come in to do a race dialogues training with our frontline staff as well as our leadership in our department. We heard about the pipeline, about workforce diversity. So this is my graduating class from 1998. That's me in the front over there. That's Hillary Clinton, 3 people down. She's the first person who called me doctor. Big sigh. Anyway, there were 36 black people in my class at Harvard Medical School, which is a feat that I do not think that HMS has repeated. But it's not always just about quantity, right? So we are our residency program as well. This is one that attracts a lot of underrepresented minority medical students. And what we've learned is that your experience in training is just as important as the number of people that are around you. And so we need to do a better job of taking care of the folks that we are training. And because certainly, you know, how we treat each other reflects how we treat our patients, right? So we can't think that we cannot be good to each other and yet also be good to our patients. We are also starting next month to collect microaggressions. So we're going to have an anonymous reporting system for all of our staff. We're thinking about heading out to our patients that they can sort of report the things that are happening to them on a daily basis that make their lives challenging to work at MGH. And then Rose and others have talked about advocacy. So there is a place. This is the time. This is the moment. These are our legislators who really are primed to hear much of this. So, you know, ACOG had its Congressional Leadership Conference a couple of weeks ago. Dr. Zera, Dr. Molina were there with Ayanna Pressley, we ran into Ed Markey in the hall. Everyone is engaged in these topics. And the asks this year really were around maternal mortality, around some of the bills that you've heard before, moving beyond 1318, which is just the authorization of maternal mortality committees, but really thinking about how can we fund the PQCs, how can we fund AIM, how can we do implicit bias training, how can we incentivize those things on a national level. You heard from Dr. Grant a little bit about the challenges of hypertension in one hospital. We need to scale some of this work up. So this is from the Illinois Perinatal Quality Collaborative, where they, over time, once you can leverage the power of a number of hospitals, rural, community hospitals, academic medical centers, everyone gets on calls and does work together in this collaborative way. They have shown a marked increase in the number of women who are treated adequately in a short time frame for hypertension. Same thing in terms of the number of women who are given patient education materials when they go home, and that over time their rates of severe maternal morbidity have gone down, and so this really works. We talked a bit about the maternal mortality review committees. I have the pleasure of serving on that committee. What I love about that committee is we really dig down deep into each patient, but what I think that the Lost Mothers series really did for us was to show us the women, show us their names. You could click on any one of these and get to people's GoFundMe page or their obituaries. We cloak the MMRCs in a little bit of cloak of secrecy, right? We're not supposed to say the name, we're not supposed to say the provider. And yet if we're working in through the lens of just culture, where everyone who showed up to take care of these patients were showing up to do their best, why can't we sort of lift that up and really learn who these people are? I'm going to breeze through this very quickly, but we heard a little bit about levels of maternal care. I think this is going to be important in terms of keeping women safe, but we've got to include the community in this, right? So if we are finding that particularly African-American women who are supposed to go to the level 4 center are not making it there, we need to use some qualitative work. We need to talk to women about what are the barriers to getting where they need to go, as opposed to this sort of top-down notion of you go to hospital A and you go to hospital B. This is from the New York Times that said why Americans' black mothers and babies are in life or death crisis. The answer to the disparity in death has everything to do with the lived experience of being a black woman in America. What I think has been powerful today is about hearing people's stories. We keep hearing how black women are not listened to, and we have heard really some powerful narratives, and that needs to be a great part of this work. Racism, not race. We heard a little bit about this toward the very end, is that we need to stop saying that race is a risk factor. Really, the risk factor is racism. And so this quote comes from Jessica Roach, who has a doula organization in Columbus, Ohio. So this idea that the perception of black families related to constructs such as poverty, education, housing instability, and race as health as a risk factor continues to validate the so-called social determinants of health rather than address the structural and institutional policies that have created them and therefore the consequences of their impact. This is her web of causation, which looks a lot like the slide that I showed you, but really contextualized in the things that cause all of those things, right? So slavery, Jim Crow, the GI Bill, redlining, the 13th Amendment. None of these things exist without these historical contexts of racism, and so we really need to speak that name. This concept of reproductive justice will come up a couple of times. So Sister Song defines reproductive justice as the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. So you heard a bunch about that in the sort of the community panel and how we need to empower women to speak for themselves, to say what they want and how we can help them to get there. And then lastly, just I think to bring it back to this notion of infant mortality that we started with, we can make change, right? So we heard that in Boston we are making change in terms of the decline in the black infant mortality rate. So how did we do that? What was new, they said in the Boston Public Health Commission, was an explicit focus on the impact of poverty, racism, associated stress on health, and that was really sort of very much impactful. And so can we apply that same lens to our thinking about maternal health and well-being? And lastly, I would just say we need to strike while the iron is hot, right? Everybody's hot to trot on this. Elizabeth Warren's got a bill. Kamala Harris has got a bill. This you heard yesterday came out in the New York Times. We were like, really, yes, we knew this, but this was really about Emily Peterson's work that you heard about from Jean DeClercq about pregnancy-related deaths and the preventability of them. And so this is like the first time that all of these organizations and many, many more that are not on this slide are all coming together. So community-based, grassroots organizations, professional societies, all aligned in a similar way. And so we really need to move this needle. And so I thank you so much. I thank you guys for listening for the panel today. And lastly, I wish everybody a happy and a safe Mother's Day. And hopefully we can sort of keep everyone safe in this context of motherhood and have motherhood change them for the better. Thank you.